I do have the recording in progress, so please be mindful of that. If you have background noise, make sure you're on mute. All right, so let's start with the GI system, okay? You really have to know the components of the GI system. So what are some of those components and what do they do? Okay, so let's start with the small intestines. What's happening there? What's the best part of the small intestines? What's it going to do for us that we care about when it comes to the digestive system? You guys can talk.
It absorbs nutrients.
Absorption.
Nutrients.
Okay, so that's where our main absorption is going to occur. All right, we first have to have food in there. That food is going to go into the stomach, turn into chyme, right? And once it turns into chyme, then it's going to go into the intestines where it's going to be absorbed. So some other things are going to help with that process, like the liver. The liver makes something called biosalts. That biosalt is going to go into the gallbladder, okay? And it's going to be stored there. And then when the body needs those biosalts to start breaking down the fats or prepare the body for digestion, then the gallbladder will release it. The liver makes those biosalts, okay? It makes them by breaking them up into smaller droplets, and that allows them to break up those fat molecules. Then you have the pancreas. Pancreas is going to secrete some of those enzymes that we need into the small intestines and is going to break down carbohydrates, proteins, fats into the smallest units so that the body will be able to use them however it needs to. And then, of course, you have the small intestines, which we just talked about, that has those pancreatic enzymes. All right, so in the small intestines, we have the carbohydrates that are going to be digested from that amylase. That's from the pancreas. All right, so if someone has something like cystic fibrosis, that's a process that's hard for them to do to digest foods. Anybody know why? What's happening in cystic fibrosis that affects the pancreas? And not just the pancreas, it also affects the lungs and every other part of the body that has ducts in it. So what happens with cystic fibrosis?
Is it because the tissues like harden with the fibrosis? Or no?
No. So things are supposed to flow through ducts, right? That's why we have ducts. Like you have ducts in your house, right? And if your ducts are clogged, what happens with the air conditioning or the heating?
The air or it can't flow through.
It can't flow. And sometimes, when we be freezing at the school, I try to put something in the duct so the air don't flow down on me. In cystic fibrosis, you have little ducts in the pancreas that release those enzymes. So it's all sticky and thick and it blocks those ducts. And these enzymes cannot be released, so they can't do their job. All right. So those enzymes are coming from the pancreas. You have amylase that's going to break down the carbohydrates. You have trypsin and chymotrypsin that are going to help digest those proteins. And then you have lipase that is going to help digest those lipids along with that bile. And then these nutrients can be absorbed through either diffusion or active transport. Active transport means what?
Energy.
They need energy. But things like alcohol and some other products go by diffusion. So that means they can easily go into the system. They don't need any extra energy. Okay, so this is why when I explained in class about blood alcohol poisoning, why do people get it? because they drink on an empty stomach. It easily diffuses into the stomach, and then it also easily crosses the brain barrier. So it can get into the blood and go into the brain barrier. So your parents always tell you eat before, during, and after drinking. So you want to know these digestive enzymes. Okay. So amylase from the pancreas for the carbohydrates, trypsin and chymotrypsin from the pancreas for the proteins, and then bile from the liver and lipase from the pancreas for the fats. Now remember, the pancreas is going to release those enzymes. They'll go into the duodenum, and the jejunum will be activated in order for that process to occur. Okay, so they'll also the pancreas is also going to release something called antitrypsin. It has antitrypsin qualities to stop the enzymes from working. If we don't stop the enzymes from working, then they can actually eat the pancreas itself. And we're going to talk about that because that's what's happening in pancreatitis, or when someone has autodigestion of the pancreas. Those same enzymes that are supposed to be breaking down foods in the intestines are actually breaking down the pancreas. So here we have that digestive system now, your accessory organs. So again, we're talking about the pancreas here. Okay, pancreas has two functions. It has an endocrine function, which you learned about when we talked about chapter 16. So this pancreas is going to produce the hormones that regulate your blood sugar. Okay, like insulin, glucagon, and somatostatin. As an exocrine gland, then it helps digest our food. So those are the two differences, okay? Exocrine, it's going to work in the digestive system, and it's producing the amylase, the lipase, the trypsin. Okay, so here again, it's just showing you that the trypsin is helping to digest those proteins, the amylase, the starch or the carbohydrates, and the lipase is helping with the fats. And then remember, you have salivary amylase, right? That's in your mouth. And what does that do?
It starts chemical digestion. Well, it
Okay,
starts to break down this the carbs in the mouth.
carbohydrates. Yeah, the
Yeah,
carbohydrates. It's going to start to break down those carbohydrates. Okay. All right. How about that gallbladder? So, that gallbladder, and this is telling you where it is. Okay. It's underneath the liver, has two functions, both of which are related to bile. So, it's getting the bile from the liver, it's storing that bile, and then it concentrates it. And then it'll send that bile into the duodenum, okay, where the fat is, and help to break down that fat. Now, the gallbladder is not a necessary component, neither is the appendix. So if one of those were to become damaged, we can remove them and the body can still function, unlike the liver. The liver cannot be removed. We need that to function. Okay, so the liver is located above the stomach, and that's going to help filter toxins from the food. So remember, we talked about this. This is the one of the final things that happens here is that liver is going to try to make sure that all the bacteria, all the toxin is out of the food, because we don't want that toxin to get in your body and do damage. It also is going to provide the bile. So that bile is going to go to the gallbladder where it's going to be stored, and it's going to help break down that fatty food. So again, gallbladder is not really a vital organ, but the liver is. So I also put on here some of the other things that the liver does, because when you have a problem with the liver, you should be aware of this, okay? These things may not happen. So you want to know everything that that liver does. So besides bile, it helps store glycogen. So when the body needs it, it can release it. It also helps break the T3, T4. So it converts T4, which is for the thyroid, into T3 so the body can use it. It detoxifies the drugs, alcohol. It removes ammonia. And we'll talk about that when we talk about cirrhosis, okay? Because when the liver's damaged, it can't remove that ammonia. And now that ammonia crosses over into the brain and causes encephalopathy. All right. So you're not going to be able to think straight. You're going to be foggy, clouded judgment. It's huge for blood clotting. Also, it's part of your immunity. And then it maintains that hepatic and portal vein system, which we talked about pretty extensively. How about your appendix? What does that do? So some people believe that the appendix stores bacteria that helps with the digestive process. It's not a part of the body that we need. Okay. So really scientists will just say that it's important for immune and digestive health, but they don't really know what it's for. But there is some belief that it does have some of the bacteria and that it helps control and maintain some of the bacteria that we need in order to have healthy digestion. Because, we need a certain amount of bacteria in order for this process to occur. All right, that was about the organs and the chemicals that are going to be released for digestion. And we also talked a little bit about absorption there. Any questions on any of that? Anything you don't understand? All right, so the digestive system has both neural and hormonal controls, okay? So we have the parasympathetic and the sympathetic nervous system, and you want to know this, all right? So parasympathetic, rest and digest. And in order for you to digest, what has to be released? What are some of the things we just talked about that have to be released in order for you to digest? Let's start with the mouth, because the mouth starts that digestive process, right?
Mm-hmm.
So
Right.
what causes that start of that digestive process?
The salivary,
Emily.
The amylase and the saliva itself, both of those together, okay? Because you need the saliva, right? The saliva is going to help move things along. Otherwise, it's going to be dry, 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 okay? So you have this increased motility and increased secretions. So those secretions include saliva and any of those pancreatic enzymes, the bile, anything that we need there for digestive. Trypsin, chymotrypsin. The sympathetic nervous system is stimulated whenever you have fear, anger, but it also can be stimulated in chronic conditions like hypertension, diabetes, burns. So anytime the body's under excessive stress, it can stimulate that sympathetic nervous system. That's going to inhibit the GI activity. It'll slow down. It won't produce any saliva here, or it'll significantly decrease it. It's going to lead to vasoconstriction, no digestive or very little digestive activity. It reduces the secretion. It doesn't allow those epithelial cells to regenerate, which we need to do. And it's all things that we appreciate because we don't want to crap our pants when we're stressed out or when we're running from a bear. All right. So you have to know this. What are some of those hormones that we're going to see released here? Okay. And what do? All right. So your mucosa cells, they're going to stimulate gastrin. And this happens when certain foods enter the stomach, certain things. It can happen when you smoke, when you drink alcohol, coffee. So this is going to stimulate gastric acid production. It will increase motility or movement. It will relax the pyloric and the ileocecal sphincters. This allows for the stomach to empty. The secretin is going to help regulate the pH of the duodenum. It leads to a decrease in gastric secretions. Cholecystokinin. This stimulates the emptying of the bile in the gallbladder to help with digestion of fat and protein. It inhibits gastric emptying. And it allows an increase in bile to flow into that duodenum. And then histamine. This leads to an increase in secretion of hydrochloric acid, which we need for certain things to happen in the body. All right, some of the symptoms that you're going to see here are anorexia, nausea, vomiting, and bulimia. All right, so anorexia and vomiting, this can happen with just about any GI condition. If you're nauseous, then likely you're not going to want to eat. Okay, so that can happen just if someone has an upset stomach. Certain foods can produce that, the flu. So that can come from a lot of things. The problem is if it's continuous. Okay, so if it's continuous, then it can lead to things like dehydration, acidosis, and malnutrition. Now, in the beginning stages, you'll have metabolic alkalosis. Why?
Because you are throwing up the acids, the
Okay,
hydrochloric acid.
you're throwing up that hydrochloric acid and you're getting rid of that potassium as well, right?
Yes.
Okay, so now eventually, if you continue to vomit, what's going to happen?
It's going to turn into metabolic acidosis.
Okay, because water is going to shift.
Shift.
Okay, so fluid here is being lost from the digestive tract, and water is going to shift from our vessels because the body wants us to be in homeostasis. So the water is going to shift to try to replace the fluid that is lost there. Okay. So initially, the vomiting causes the loss of the hydrochloric acid from the stomach and the metabolic alkalosis. But if it's prolonged and severe, then dehydration and metabolic acidosis will develop. Another thing that can cause this is think about this when you're vomiting and you're dehydrated, your body's going to conserve the blood, right? And blood is what's bringing the oxygen out to the tissue. So when the tissues don't have oxygen, they have to switch over to anaerobic. Okay. In order for metabolism to continue in the body, they have to switch over to anaerobic metabolism. And when that happens, the body is going to produce lactic acid, and that is going to cause an acidotic state as well. Anorexia would usually happen before we're nauseous and before we vomit. Sometimes people have anorexia and they eat, and that causes them to vomit. Nausea itself, just that unpleasant sensation stimulated by things like distension, irritation, or inflammation of the digestive tract, which can happen because of a few things. Also, certain smells. Okay, this can happen especially to your chemo patients, to your pregnant patients, right? Or to you as the nurse on the floor if something hits that nose the wrong way and you catch yourself, stepping to the side. You may not necessarily vomit, but a lot of times it takes everything you have to hold back from it, right? Because you're gagging. How about a sight of something? So visual images. So what makes you gag? For me, it's mucus. I don't like to suction people because if a big loogie or something comes out, I'm done. I might throw up right on them. So what induces that? Okay. what are we going to see in patients when this happens? So if it's a lot of vomiting taking place, there's fluid shifts going on, they're losing fluid, then we'll see things like dizziness, irregular heart rate, low blood pressure, and that can make the cells not function well. So because of the lack of the function of those cells there, that can lead to poor concentration and focus. We can have shortness of breath because we have low blood pressure. We have an irregular heart rate. That means the blood's not getting to the tissue. And that's going to lead to shortness of breath because of the oxygen missing there. And then if we develop something like acidosis or alkalosis, then the body's going to change the way you breathe. So that can also contribute to shortness of breath. You can have bloating, abdominal pain, and muscle weakness, all just behind this. And those are also classic signs that we'll see in someone that has anorexia nervosa. So because they're doing continuous either vomiting or not putting the food in. You need food in order to regulate your body, and they're lacking that food. So their body's not getting any nutrition here. In order for you to make those red blood cells, what do you need coming into the body? Protein, iron, okay? In anorexia, they're eating maybe a pea a day or one French fry. It might not even be anything of nutritional value. One potato chip. If you ever watch somebody with anorexia, they'll tend to eat more junk foods. And it's probably because they're a little bit more filling. So if I only got to eat one thing, they're tricky too. They'll try to manipulate you. All right, bulimia. This is when they're almost a normal weight, but they'll binge and purge. So they'll eat a lot of food and then throw up afterwards. So because of that, they'll have scars on their knuckles from sticking their fingers down their throat. Irregular menstrual periods. By the way, anorexia is going to have amenorrhea, more than likely no period. Irregular menstrual cycles for bulimia, muscle weakness, dehydration, and they can still have the same electrolyte issues. And then binge eating is when they overeat. So this is going to be people that end up with things like diabetes, high cholesterol, obesity. Your book doesn't talk too much about that. All right. So with metabolic alkalosis, that's going to be from that loss of that stomach acid. We can also get this if we suction someone too much. So we would be suctioning people in conditions where the stomach might be bloated or too much gas in it for some reason. So this might be if someone has a severe burn or if they have something like abdominal surgery. So we have dehydration, hypovolemia. These are common complications of those digestive tract disorders. We lose the electrolytes in the vomiting and the diarrhea. The alkalosis is usually going to be from the vomiting and the loss of the hydrochloric acid and the potassium. The acidosis is typically from diarrhea. So we're losing heavy bicarb in the stool and we're not absorbing fluid or glucose here. So remember, acidosis mostly with diarrhea, but if they asked you about excessive vomiting, then you would say acidosis. If it's just normal vomiting, it's going to be alkalosis. Any questions there? All right, cleft lip and palate. This is genetic. It's considered a congenital issue here. Usually it's inherited or due to some sort of environmental factors when they're in utero. Okay. I would know the difference between the two of them. So the lip is failure of the maxillary processes to fuse with the nasal elevations, and palate is where the hard and soft palate doesn't fuse. So palate is going to be in the mouth. Lip is typically going to be on the outside where you can see it. But sometimes you can have them together, as in that picture down there on the bottom right. You see they have the cleft palate and the cleft lip. Main issues here are going to be feeding, okay? Because you can't feed the baby here without a special nipple. We will do some sort of surgical procedure. You can feed them, you just need special equipment to do it here. So, not until they've been seen and we have that equipment in place. Periodontitis. Typically, people start with gingivitis here, okay? And then they're not taking care of the mouth. Eventually, they develop this plaque and this calculus on the tooth that causes inflammation around the tissue on the tooth. The gums can easily bleed, they become red. The tooth itself or the teeth around that area are going to feel loose. Most of your causes of this are poor oral hygiene. So they're just not brushing and flossing. Smoking. People will see some changes in the teeth with cancer and chemo. Sometimes with diabetes, they can have poor healing. HIV can also be attributed to periodontitis. Common cancer for the mouth is going to be squamous cell carcinoma. So this is going to affect mostly smokers, people that have pre-existing leukoplakia, and those with a history of alcohol abuse. So the top picture is like the border of that tongue. That's where it likes to lay. But you can also have it like on the lip. That bottom picture is the lip. These tumors tend to have a poor prognosis because they're hidden. Sometimes we don't even know they exist. And risk factors are things like tobacco, alcohol. Kaposi's sarcoma, this happens in your AIDS patients. So a lot of times, and when you get to med surg, you'll have to know this because they ask about this all the time in med surg. But usually we see this on the skin, but you can also see it in the mouth. All right, so we have lesions there, either flat, elevated brown, or purple lesions. That's usually the definitive colors there that they tell you about. It can cause ulcerations, bleeding. So this is a type of cancer actually that develops mostly in your AIDS patients. Dysphagia. So it's difficulty swallowing. There can be a couple reasons why, because of some kind of structural issue. It could be functional, like some sort of muscular or neurodegenerative disease. So that would be like muscular dystrophy or um, Lou Gehrig's disease. Structure could also be from cancer or certain types of diverticuli. Um, it could be caused by solids or liquids. Okay. And symptoms for this are going to be things like heartburn, regurgitation, chest pain. Neurological factors could be a stroke, an infection. And with that, usually they have that failure of the lower esophageal sphincter. So it's not being innervated by the nerves, by the system that's supposed to innervate it neurologically, okay, from your brain and from your nerves. So it's not being innervated here, and that causes the failure of the lower esophageal sphincter. We'll talk about that in a second. That's something called achalasia. All right. So structurally, they could have a problem with solids and liquids in the esophageal area because of cancer, strictures, esophagitis, and motility would be more of the achalasia or GERD. So the achalasia, that is the failure of that lower esophageal sphincter to relax because it's not being innervated here. So you see there where the achalasia is. If you look at the picture on the right, you see that little stricture there. It's squeezing off. Okay. The lower esophageal sphincter is a valve that's supposed to open when the food is swallowed. In achalasia, it doesn't open up and that makes the swallowed food dump into the esophagus area. So chronic inflammation can develop in the esophagus, and the reflux of the food there can lead to aspiration when the person lies down. It also puts them at an increased risk for esophageal cancer. Another issue that could happen, and these are usually congenital, these happen in babies. We'll usually notice it right away when the baby's born, okay? These are going to be have to be fixed before we can feed the baby. We'll keep the baby NPO. So esophageal atresia, this is where the esophagus fails to elongate and it doesn't connect to the stomach. The tracheoesophageal fistula, this is where there's a connection formed between the trachea and the esophagus. So food can go down into the trach. These are considered congenital, all right? And sometimes they'll occur together. The main issues here is aspiration. So these babies are going to present usually with the 3 C's: coughing, choking, aspiration. I'm sorry, coughing, choking. That should say cyanosis. Coughing, choking, cyanosis. All right, which are signs of the aspiration. I'll fix that slide. So 3 C's: coughing, choking, cyanosis. You see the picture on the right? They show the blue of the baby. These babies are going to be blue from that choking. All right, next up is hiatal hernia. Okay, and this is where we have part of the stomach going through the opening in the diaphragm, and it's going to be near that thoracic cavity. All right, so if you look on the right versus the left, if you look at the top of the picture where it points to the esophagus and the diaphragm, you can see that it's bulging there. Factors that contribute to this are shortening of the esophagus, weakness of the diaphragm, increased abdominal pressure from pregnancy. Sometimes we'll see this in clients that have had gastric bypass. Here, the food is going to stick or lodge in the pouch, and that can cause inflammation of the mucosa. It can cause the food to reflux up the esophagus and dysphagia as the food enlarges and obstructs the passageway. So this increases the risk for reflux. These clients can have heartburn or pyrosis, which is a substernal burning sensation. And a lot of times they'll have a sour taste in their mouth from belching. And then some of those other symptoms you're going to see are chest pain, heartburn, abdominal pain, belching. GERD itself is that gastric content flow into the esophagus. This can happen approximately 30 to 60 minutes after you eat or at night. You have that reflux of that gastric acid, and that's causing inflammation, ulceration of the mucosa there. It can lead to fibrosis and stricture in the esophagus. This is often seen with hiatal hernia. Things that can lead to this are increases in the lower esophageal pressure, caffeine, fatty foods, alcohol, and smoking. So if you notice, a lot of these are caused by caffeine, alcohol, smoking, fatty, spicy foods. That lower esophageal sphincter not working. Next is acute gastritis. These clients will usually appear with anorexia, nausea, or vomiting. With acute, it could be mild. They might only have vague symptoms. But if it becomes more severe, they could end up with an ulcerative or a hemorrhagic episode where they could bleed. Okay. Usually with this type of bleeding, they're going to vomit and they'll have those GI signs and symptoms of that coffee grain. If it's I was going to say something else there and I lost my train of thought there. Oh, I'm sorry. If it's coming out in the poop, then what color is it going to be?
Is it gonna be the clay color?
So clay colored is usually going to be if there's something wrong with the liver, the gallbladder, or the pancreas. In an
What
upper
was the
GI
question?
in an upper GI bleed, so this would be considered an upper GI bleed if they had a bleed here, right? What would the poop look like for an upper GI bleed?
Bright red.
Dark?
Is it going to be bright red?
To be
Red?
dark.
Dark
I was
and
about to say
terry?
dark.
It'll be dark. It'll be dark.
Dark and tarry is correct.
Yeah.
Bright red is going to be associated with things like hemorrhoids or some sort of tear in the lower anal area. Okay, so some things that could cause this are like
Okay.
really hot peppers, NSAIDs, alcohol. You know, when they do those ghost pepper challenges, that's fun today, but tomorrow your stomach may not think it's so fun. Other things that could also cause this are allergies to shellfish or certain drugs. Any questions on that?
All right, real quick. Yes, I do have a question. So you said upper GI stool is like dark and tarry, and then the you said problems in the liver, pancreas, and where else did you say that they all had the clay colors too?
Clay colored is going to be usually if there's a problem with the liver, the pancreas, or the gallbladder.
And then bright red is for the lower, correct?
Bright red is lower. That's usually going to be something out of the anus. Usually some sort of hemorrhoids is the most common cause, either internal or external. You may not necessarily see them depending on where they are. Any other questions on that? All right, so in chronic gastritis, okay, this is characterized by atrophy of the mucosa. Remember, the mucosa is protecting the stomach from the acid eating away at it and causing damage. Okay, so with chronic gastritis, we'll have a loss of those secretory glands that secrete that mucus. We'll have a loss of the parietal cells that produce the hydrochloric acid. So that causes achlorohydria, and we'll have a reduced production of that intrinsic factor. And this is why sometimes these people will develop pernicious anemia. Common causes can be age, so elderly or older adult, chronic peptic ulcers, alcohol abuse, H. pylori. They'll have an increased risk for peptic ulcers and gastric cancer. And sometimes this can be autoimmune. So again, if you look at it, most of this for gastritis is from irritants to the stomach, okay? Irritants, especially to the lining of that stomach. So what kind of things are going to irritate the lining of that stomach? Caffeine, cigarettes, alcohol, NSAIDs, and that H. pylori infection. Could also come from extreme stress, okay? So when someone has a burn, we usually give them, if it's a severe burn, we're going to give them proton pump inhibitors to prevent what we call a curling ulcer because the amount of stress in the body, remember, stress causes vasoconstriction. So that means we're not getting fluid or blood flow to that area. So in chronic gastritis, we have a loss of those secretory glands. Okay, so we're losing some of that mucus being produced, but also the loss of those parietal cells causing a chlorhydria. Anything that starts with A means without. So this is without hydrochloric acid. And I put a little picture down there so you could see what normal is. Okay, how much hydrochloric acid should you have in the stomach versus what these clients have. Any questions? All right, next is gastric and duodenal ulcers. These are most commonly caused by H. pylori. A lot of them are going to be in the duodenal area, but they can be in the stomach. And it starts with breakdown of that mucosa that we were just talking about. Okay, so now if you don't have the mucosa, that slimy little stuff that's in that stomach, that's protecting the lining of the stomach. Okay, so we don't have that. And these people are typically producing an increased amount of acid in addition to that. So now we have things like epigastric burning because that acid is eating the lining there. Aching pain 2 to 3 hours after a meal, a lot of times at night. So they'll try to relieve that pain by eating food or antacids, or some people drink milk. They'll have symptoms like heartburn, nausea, vomiting. They can have weight loss as well. And if they eat something that irritates, like alcohol or food, it could cause them to vomit. And then they can develop iron deficiency anemia here. They can develop B12 deficiency anemia. So if you look at the picture here, it's trying to show you how the H. pylori, why is that a problem? So look at what it's doing to the mucus layer that's supposed to protect the cells there. It's eating right through it. All right. So is the acid. The acid has now found holes or weaknesses in that mucosal area, and it's able to pass through and cause damage or cause an ulcer. Because if you look all the way to the right there, that mucosal lining has been damaged or removed, or it's not there. So the problem is, this can lead to hemorrhages because of the erosion from those blood vessels. And that might be the first time they realize that they have a peptic ulcer. So maybe they vomit some blood. Or, they could have it in the form of stool. But if you have blood in that area, what's it going to do? It's going to irritate, okay? So that's, when you see people have those GI bleeds and they throw up, the area is irritated because blood's not supposed to be there and your body don't like it. So it's trying to give us a warning sign. Perforation can happen here, and that can end up with peritonitis because if the ulcer erodes through the wall, then the chyme leaks into the peritoneal area. What are signs of peritonitis?
Stiffness and swelling in the belly.
Hypotension,
Tachycardia.
tachycardia, sweating. That was on your Jeopardy. I would go back and look at that. All right. Obstruction may result later because scar tissue can now form in this area as well. Dumping syndrome. Okay. This is when they have a problem there with the gastric emptying. Okay. So it can happen after a gastric resection. Usually damage here to the pyloric sphincter, I believe it is. So what are we going to see in the client?
Their blood sugar, doesn't it start off going up, and then it just drops
Yes.
after the meal?
Okay. It just drops because first it goes up, and your body's response as part of that negative feedback loop is to release insulin because it recognizes that you have this food, undigested food it is. It doesn't know that, but it just knows that it has food in there. All right. So again, this is usually because the pyloric sphincter is removed. I really should have put that on the slide, but I want you to understand that's why this happens, that pyloric sphincter. Okay. So that's why we'll sometimes see this in people that have gastric resection or gastric bypass. All right. So now the body can't control the gastric emptying, and it goes in there really fast because remember, when we talked about the GI system, one of the things that I said is that sphincter allows small amounts of food to go in there a little bit at a time so the body can handle it and process it, right? But now we have this big amount that's dumped in there. So the hyperglycemia with that insulin being released, and then we're going to have hypovolemia. Why? Because that chyme is very hyperosmolar here. And osmolality means what?
Uh, like more concentrated.
Okay, or salty. Remember salty? Remember my salty bitch conversation? So when you're more osmolar, you're saltier. And so that salt is going to draw what there?
Water.
Sodium?
Water or fluid.
Water. Okay.
Well,
It's
water,
going
yeah.
to pull that water or that fluid into the intestines, and it's pulling it from your vessels. Okay. So now you're going to become hypovolemic. That's going to lead to the weakness, the dizziness, the diaphoresis that they experience. Also, the tachycardia. Now they can have some abdominal cramping here, right? And the food is going to go right out. So when the food goes out, now we have this high insulin that was released in the body, but we don't have any food there because the food left out real quick. All right. So that causes the blood sugar to drop down and they become hypoglycemic. Any
Before you
questions on
move
that?
on, yes. So, you said they become hypovolemic due to the chyme being osmolar.
Hyperosmolar.
Okay.
So it's really concentrated there. Okay. So when you have an area of high concentration there, it's going to pull that fluid in there, right, to try to level it out. And where's that fluid going to come from? So that's what causes that hypovolemia. All right, pyloric stenosis. This is where we have narrowing and obstruction of the pyloric sphincter. This mostly happens in infants, but it can happen to people as they get older. So if it happens to the baby a few weeks after they're born, they'll start to have episodes of regurgitation at first. Eventually, it'll become the projectile vomiting, and it'll happen right after they eat. So with projectile vomiting, we'll either see it induced with food, which is pyloric stenosis. When we see it without food, what is it typically caused by?
Increased intracranial pressure.
Yes, increased intracranial pressure. So I just want you to be aware of that. When you see a question, you got to know that. They may or may not ask you about it, but it's good to know because you may see questions about that in life. All right, so here the baby's hungry, we feed them, and then he starts projectile vomiting. The baby is going to end up looking dehydrated. Okay. Anterior fontanelles sunk, eyes sunk, decreased elasticity of the skin, and they're not gaining weight. So they become failure to thrive. They'll have small, infrequent stools, and they'll be irritable. We're going to have to remove the obstruction because they're not gaining weight. They won't be able to gain any weight because the food is not staying down long enough for them to absorb any of the nutrients. It's not even making it actually to the intestines. Why?
Because it's not being absorbed. It's not being digested.
So it can't get through that pyloric
Well,
sphincter.
yeah.
The pyloric sphincter releases the food there, right? And that's blocked or small, so enough can't get through there. Your hepatitis, you should know. Okay. Hepatitis A is going to be fecal oral. Okay. So this can come from contaminated water or shellfish. There is a vaccine available. And a lot of times this happens to people traveling, food care workers, healthcare workers. The fecal shedding has the virus in it. So when you touch the poop, your hands, your nails aren't clean, you pick up something else, it can end up in your mouth. The bacteria gets in the food. Or you eat that shrimp, that clam, whatever, that's contaminated from the water. Hep B being all your body fluids, everything wet except sweat. A lot of these people are asymptomatic but contagious. This is chronic. Hep A is not. Hep A is self-limiting. So it'll last 6 or 8 weeks, depending on the person's status, and then it's going to go away. But with Hep B, what will happen is the symptoms of the infection may go away, but they still have the infection in the body dormant. Okay. It's chronic. So it's mostly transmitted by infected blood, semen, but it's in all body fluids. So you can get it from saliva. You can get it from a tattoo. There is a vaccine available. Usually we start giving this to babies at around 6 months old. Okay. Trump wants to stop giving it to them. People are nasty. There's a lot of nasty diseases going around. Be careful. Hepatitis C. See you later. You're probably engaging in IV drug use or risky sexual behavior, or maybe you got a blood transfusion. A lot of these clients will be in a chronic carrier state. This increases the risk for liver cancer. And then Hep D, okay? And Hep E. Hep E is similar to Hep A. Hep D usually goes with Hep B. So if you have a Hep B infection, you could end up with a Hep D. Questions? Cirrhosis. Okay, this is going to be damage to the liver. The liver's in your right upper quadrant. It's going to become scarred. It can develop chronic inflammation and it'll be destroyed here. What's that liver do? We looked at that in the very beginning of the chapter or the review, okay? And we saw that it's responsible for things with digestion, metabolism, detoxification, blood clotting, things that could cause it to be damaged. So, chronic viral hepatitis, excessive alcohol, non-fatty liver disease. What are going to be the symptoms? Okay. Jaundice is one. Now, typically, what causes jaundice?
Bilirubin. Bilirubin.
The breakdown of those red blood cells, right? Or elevated bile because the liver's not able to break down the bile or use it in the body and get rid of it. So encephalopathy, that's because of what?
Elevated
Ammonia.
ammonia levels in the
Elevated
brain.
ammonia levels. So when the body's using the protein and the ammonia is a byproduct of that, it's not able to process that ammonia and get rid of it. So it goes to the brain and causes that confusion, that fogginess. They can also have spider angiomas, which are like blood vessels, little blood vessels throughout the body. Ascites, that's going to be that fluid in their belly. Red palms. Liver usually will affect the palms of the hand and the feet. All the little things here that can happen. So the budding of the breast, that's called gynecomastia. The esophageal varices, where you have those little bleeding vessels in your hepatic portal system. Anorexia, impaired digestion and absorption because you're not producing bile, then you have none stored in the liver and it's not going to be able to break down those fats and lipids. Fatigue, you're lacking energy, increased bruising because blood clotting system here, the liver is responsible for. Any questions on that liver?
No.
Okay, now we're going to talk about pancreatitis. Okay, so this is inflammation of the pancreas and it causes it to eat itself or auto digest itself. The activated enzymes, the trypsin, the amylase, the lipase will start to digest that pancreatic tissue, and that causes massive inflammation, bleeding, and necrosis. This can be acute or chronic. It is a medical emergency. And we're not going to feed these patients because feeding them will trigger this because the pancreas is responsible for digestion. So we don't want to trigger the digestive process here. The pancreas itself doesn't have a capsule around it. So, when we were talking about pain, how we were saying with visceral pain, there's a capsule around the organs like the liver. And if that capsule stretches, it causes pain. The pancreas doesn't have that capsule around it. So because of that, when it releases certain substances, it can cause it to damage it. There's a sudden onset of a large meal or a large amount of alcohol that can lead to this. Typically, it didn't happen because you had one large meal or one large bout of alcohol. All right. You've been doing this for a while and it just caught you. All right. With acute pancreatitis, they're going to have colon sign, which is bruising and pain around that belly button. Gray Turner sign, which is usually bruising and pain or tenderness in the flank area. Epigastric or abdominal pain that radiates to the back. And the pain increases when they lay flat. So usually these clients will present in a fetal position. Signs of shock. So low blood pressure, pallor, sweating, rapid, weak pulse. They can develop hypovolemia with inflammation and hemorrhage. Low grade fever. If there is a hemorrhage, okay, if there is other damage, of course, that can lead to decreased bowel sounds, peritonitis, and decreased peristalsis and paralytic ileus. Paralytic ileus is what? Use your terminology here. Okay, what's happening in the ileus? Things are moving, right? Peristalsis is happening there. What's paralyzed mean?
You can't move.
It's not moving, right? So here you have a paralytic ileus, you have lack of peristalsis, decreased peristalsis.